disease that mimics, and a lot of times they'll say that they think that it mimics like MS. So that's why when these patients present, it may be just process of elimination. They do have weakness, muscle wasting, so they do have a lot of atrophy in their muscles. It begins with twitching of muscles. They may seem to, maybe they trip more. Maybe they notice their speech is more slurred. Over time, it does lead to complete paralysis. Age is between 40 and 60, more common in men. My great uncle just passed away of this, and the one thing he told my mama was that he just wanted, he knew like his wife was trying to take care of him, trying to do everything for him. He just said, this isn't even living. Like, I just want to go. It's not even living. And but he stayed in his right mind, and most of these patients do. They understand and they know what's coming because we educate them. In the end, with paralysis, so what do they eventually die of? Do you know? Respiratory failure. Because their diaphragm, everything is paralyzed. They are unsure what causes this. They say possibly even in the military could increase risk, maybe due to the chemical toxins and things, maybe where they're going. So again, I kind of went over what we see, which mimics, again, that MS. Testing purposes, again, there's not really a diagnostic measure that they use. They may check the muscles. They may do the electromyography test on them to see how the muscles are conducting, how everything's moving through. They may do MRI if they suspect maybe MS again. They may even do a muscle biopsy. When they do all these tests, 6 months later, they'll repeat the test because they want to see if it's gotten a lot worse. Then that's when they usually can diagnose them with ALS. So we know the end result is in curing this. What are some things that we would want to do with these patients? If we know respiratory failure, what is important that we know? What about directives? Advanced directives. That's very important for these patients. We want their input because what do families often do? They want more. They, and I know, we've been there, making those decisions is tough. But we want to respect the patient and what they desire. So this is important to kind of get ironed out right away, just so that everybody knows what to do for the patient. Management. There is a medication that can slow the disease, Riluzole. Again, does it cure it? No. Supportive care. So again, we're doing management of the symptoms that the patient is experiencing. Psychosocial support. Again, this patient, the disease process does not at all affect the mind. So any kind of psychological changes that we see, mood and things like that, is due to, probably depression due to the disease process. PT/OT speech therapy can help with these patients. Nutrition. So again, we may do medications if they're producing a lot of saliva. So Again, if we're losing the ability to swallow and things, then the saliva kind of gets stuck in their mouth, and then they're at risk of a lot of suctioning, things like that. Constipation, depression, sleep, nutrition, all those things are important for these patients. Guillain-Barré, what I want you to write on your paper or type on your form, ground to brain. So it's ascending paralysis. It starts at their feet. Ground. So ground to brain. So GB, ground to brain. So it causes impaired mobility, sensory perception, as a result of altered immunity. So again, we see this destruction of the myelin sheath. That's why we have all of those symptoms. It's important for us to know the chronological order of this, because sometimes if they've already, maybe now they're having urinary incontinence, it started in their feet, now they're having urinary incontinence. When patients come in, sometimes they start all over the place. Well, this is what's going on, and you have to say, okay, tell me in order how it started, because that way they can think back, and they can write down how it began. The nice thing about this, the only nice thing, is the healing occurs in reverse order. So once it ascends up, most of these patients do have to be put on a vent, but once they begin to heal, everything, when they start getting their feeling back, it goes in the reverse. So they'll be able to breathe, and then they'll learn to kind of walk again and all those things. Yeah. A patient that I had her in home health, but so she was already out of the hospital from this. But her and her husband used to go they went on monthly cruises. So when she got back, I'm pretty sure it's just when COVID happened that I had her. So she said that she was on a cruise, she got really sick, and then within a week or two later, when she got home, that's when she started knowing all these things. So they related it to an infection that she had. 3 stages. Within the acute initial period, usually takes between 1 and 4 weeks. That's when the first symptoms occur. The plateau period can last several days to 2 weeks. Recovery phase, depending on how quickly they treated it, can be 4 to 6 months, up to 2 years. But sometimes those symptoms can linger if they sought treatment late. So again, this is what we see has caused GBS, the bacterial infection viruses. They may be definitely going out of the country. She picked up something, and this is what it resulted in. Manifestations. So again, those symptoms in chronological order, we want to know that. Loss of reflexes. So when you're taking care of a patient, they come in, they have this diagnosis. When you're on the floor with these patients, it is crucial and critical that you are assessing them, if not like twice a shift and not more often. And again, you'll have orders for that, but definitely once a shift as soon as you go in. How do we know if it's ascending? Like what kind of things can you do as a nurse that tells us if it's ascending?
Where they were when you assessed them. If you assessed them more than like the beginning of the shift, and by the end of the shift, there's something else going on with something higher than what you assessed initially.
So loss of reflexes, that's one thing we can do. You want to know interventions as far as ways that we can tell if their respiratory system is compromised? Maybe they only had weakness and numbness in their legs. Now they're incontinent of bowel and urine. They may be limited in their movement. Cranial nerve testing. Again, the ability to shrug your shoulders would tell what if it's, all the way up here. So then we worry about the breathing, especially if it's right on the diaphragm. So those are things that we're doing with these patients. So we want to assess for any type of pain, anxiety, especially anxiety with these patients, because usually when we review this with them, we're going to tell them that it can cause them to be put on a vent. Earlier the treatment, the better, though, because they may not be on a vent very long, as opposed to somebody that waits for a long time and then they have to be put on a vent for a longer period of time. Some of the viruses that we've seen: flu, the cytomegalovirus, the Zika virus, which we're going to hear about now. Diagnostics and testing, they may take some fluid samples like CSF and check for any kind of infections. CT, MRI may be utilized to rule out other causes. The plasmapheresis, if they definitely diagnose them with GBS plasma, they'll do the plasmapheresis where they take the blood in the plasma out and then filter the plasma out, because what does the plasma contain? Antibodies, and that's what's causing this. They'll reinsert the blood and whatever component they add into that to make up for the plasma. The IVIG, they can do this with these patients. However, with this, it can cause retinal necrosis when administered and anaphylactic meningitis. Yeah, necrosis, yep. With this, usually if they get IVIG, usually 24 to 48 hours, they show really good signs of recovery, and they heal quicker. One thing to know, if you ever have a family member that you think that could possibly have this, don't take them to Thomas. And I'm not knocking Thomas. Thomas does not do plasmapheresis. This is what my patient told me, and she said she went to Thomas, and then they basically said, "Oh shoot, you have this. We don't do that here. You need to go to General." And then when General went to take her, the insurance didn't want to pay for it because you can't do 2 ER visits in a day. So they did get it covered. I'm sure the doctors wrote them a new one. But just be mindful of that there are only certain hospitals that take care of this. Nursing intervention. So airway breathing, we want to do supportive measures with these patients, monitoring, turn, cough, eat, breathe. And maybe one mechanical ventilation. Circulation, so cardiac monitoring. You want to monitor for any arrhythmias. And mobility, PT, OT, they may need assistive devices, especially when they go home. You want to monitor their skin integrity because they're not going to be able to roll like they should. We want to prescribe pain medications, but we want to be very mindful of the respiration. We want to assess for any malnutrition at least 3 times a week. Just to check to see their weight and all of that. And if they are, then they may need to take tubes or something. Myasthenia gravis. And we're going to think of the reverse, mind to ground. So we have acetylcholine receptors, and what happens in our body is these antibodies are formed and they block the acetylcholine receptors, and then we cannot produce muscle contractions. So then we have muscle weakness. This commonly occurs first, and it's a good thing that it occurs first in like the eyes, around the eyes, because it can move down. So we catch it earlier. Again, we want to know the chronological order of the symptoms and how it began. They found that hyperplasia of the thymus gland sometimes can cause myasthenia gravis like symptoms. So if that is what's causing this, they can remove the thymus gland and then patient's fine. But we're talking about this disease process, so I'm not going to be testing on the thymus. Key features. So again, things that we see. You have your ocular palsies, ptosis. This is that droopy eyelid, double vision. And again, symptoms as they move down, so respiratory compromise, loss of bowel and bladder. Sensories, they can have, feelings of like those pins and needles in their skin. Things that we may see that these patients, that causes this. Menstruation. So women that go through menstruation may see more symptoms of this. Vaccinations. Exposure to temp changes, so real hot, real cold, and then infections. So when you're assessing these patients, you want to check those cranial nerves, and then, obviously you want to check their shoulder shrug, and then check their respiratory because you want to see how it's moving down. Hopefully you catch it a lot sooner than before they have to be on mechanical ventilation. So diagnostic testing. So obviously they may do some thyroid function tests. They may look at the nerve stimulation. They may check your blood for the acetylcholine receptor antibodies. They may check the muscles higher up to see about the conduction. And then the real testing the gold standard testing that we see is the insulin testing. So the insulin testing, they give a medication, and if it improves within the first 30 seconds or so, and it lasts for 4 to 5 minutes, they will diagnose the patient with myasthenia gravis.
Within minutes?
It'll only last a few minutes because it's a very low dose.
Oh, okay.
Yeah. It usually improves within 30 to 60 seconds, and then it lasts only a couple minutes because they want to see, because they don't want to give too much, to where it pumps their body with medication they may not need. Crises. So I tell this every semester, so when you all to prove me wrong, know this. It'll be on your test. Star it, underline it, whatever, but know it. Myasthenic crisis is when they are under-medicated. Cholinergic crisis is when they are being over-medicated. that we got to be mindful of when these patients are taking medications and they're diagnosed with myasthenia gravis. Things that can precipitate it is over-the-counter medications. Okay? We tell them you don't take it unless you ask your doctor. So, laxatives, Valantin, beta blockers. Again, your seasonal changes, obviously we can't change that, but hormonal changes, again, when they're menstruating, stress, alcohol, infection, like I already told you, heat, anti-arrhythmias, all those things could cause myasthenia gravis. So now we know if you see it on their list and they're just diagnosed with it, then you would probably go to the physician and say, hey, I know this thing can precipitate these events. So then they would look at it and change their medications up. So again, we're monitoring the respiratory system. Plasmapheresis can help because it can take out those antibodies that are blocking those receptors. Again, you have your test here, the Tinsulin test. And then your immunosuppressants, your corticosteroids can help to block, antibodies, but it's not really the treatment for myasthenia gravis. Your treatment for is the cholinesterase inhibitors. Now, if we know we get weaker, so the more we do, the weaker we become. When should we take this medication? Before you do anything. It's almost like your thyroid medication. You always take Synthroid an hour before you do anything in the morning. So this would be the same type of medication. You would take this medication before you do anything. Get up at 5 a.m. If you're up at 7, take it at 5 a.m. because we don't want these patients to eat. And they're eating a hefty, say some pancakes, all this stuff. They're like, oh, shoot, I forgot my medicine. And then they may be so weak they can't take their medicine. So that's why it's really important to educate these patients. The cholinergic crisis, so this is important to notice differences because maybe when we start them on a medication, they exhibit those symptoms. And if we understand the differences, then we may be able to see that it was too much medication and we can back them off a little. Light activity, obviously overexerting themselves. Even, when they have their weak facial muscles, asking them a lot of questions or doing those things, we need to be cautious of doing too much at one time because it can cause weakness. Now we move into CP. So CP is an abnormal disruption of the brain. It can be caused due to infections. Hypoxia is one of the main causes of CP. Maternal infections may not be infant infections, but maternal infections, along with head injuries, maybe during birth. Risk factors, so again, maternal health. We are assessing the patients during pregnancy for any infections. One thing that we always assess for, and during a prenatal workup, we're doing syphilis testing, we're doing making sure they've had their vaccines. One big thing I remember when I lived in Illinois, I always had to, especially when my patients would go visit their families in Mexico, I would always have to do Zika screening on these patients. So depending on where you live and where they're traveling, you just have to stay up on that kind of stuff. Infant illness, so fetal stroke, infections, maybe during the birthing process, they may have went through hypoxic episodes. Other pregnancy, birth risk, traumatic brain injuries, lack of oxygen. Symptoms of CP, you have variations in muscle tone. They may have a lot of spasticity. Their muscles may be rigid. They may have contractures, especially later on, tremors. They may have convoluted muscle movements, and I'll show you all a video with what I'm talking about whenever I say that. Excessive drooling, so again, they're at an aspiration risk. Delays in speech is very common. Difficulty with sucking early on. Taking a bottle or breast. Seizures. And really, when we recognize these things, if we don't know right away that they've had maybe had trauma, one thing that we may see is the delay in motor milestones. Movement. So difficulty with vision or hearing, intellectual disabilities, oral diseases. Why would they have oral diseases? I said it on the previous one. So the drooling can cause oral diseases. Mental health conditions, anxiety, depression, urinary incontinence. Early signs. So again, failure to meet these developmental milestones. Setting up, crawling, rolling, all these things usually within a certain time. If we don't see this occurring, then we may start looking into this a little bit deeper. Feeding difficulties, so early on feeding difficulties, what can we do for a family that maybe the infant is or newborn is having feeding difficulties? Who can we get in with them? Speech therapy, because speech therapy works with latching and can also help with the feeding difficulties. Things that we assess for persistent gagging and choking, obviously aspiration risk, failure to smile, lack of interest. So again, all these things can indicate if a patient has CP. Now it doesn't necessarily mean CP, but we're going to assess the patient. Complications again, contractures can happen. Malnutrition due to swallowing, feeding difficulties. Lung diseases, eyes, muscles. So a lot of times they'll have to definitely go to your eye doctor and stay up with that. Prevention, maternal prevention, their vaccine, making sure you're vaccinated for certain things. Good prenatal care throughout the entire time. Practice good child safety. History taken, physical exam, MRI may be used to rule out. And then management. So they may have to see several different medical teams. And when I say this is because it really is individualized. My cousin who has this he was 18 before he walked. He does not speak. What I love about school programs is he is probably 25 and he repeats his senior year over and over and over, and they allow him to do that. He can talk to us through the computer. Very, very smart. He does walk with a walker at times. He's mostly wheelchair bound. But then I had a student in here one year. He said, my daughter was diagnosed with CP, but she did have some school delays, but other than that, she's been perfectly fine. She runs, she jumps, she's played sports. So it's really different among all children. One thing you want to avoid with families is false reassurance. Um, so for somebody that, they want to know, will my baby ever walk? That's just something that we would say, well, we just have to monitor and, do PTOT, things like that. But we wouldn't say, oh, I'm sure he will, or I'm sure she will, because that's a false hope that we don't want to plant. Things that we may be able to do, they do use Botox for the muscles sometimes, because it does help relax them. We want to promote socialization. Obviously, we want to, monitor if families are going out in public with their child, because we don't want families just to keep them inside and think, I don't want anybody around them, because they do need that socialization. Xanaflex is a muscle relaxant and it also helps with the spasms, because they do have, their contractures, everything can be very painful. Things that we may do, a lot of the children that I've been around, if they're gripping with their hands, what can we do for interventions? Because if your nails are going into, what can you do? What else can we do? Yeah, braces. We can even do. Some people even like if they're in the hospital, we don't have a brace or something available to us. You can roll up a towel or a washcloth and put them in their hands so that it kind of opens them up a little bit. So those are all interventions that you can do with the patient. Again, PTOT, speech therapy is important. Like Carol said, we may, for nutrition, if they cannot consume food via mouth, then we could do peg tube, things like that for other